Woolhouse, OBE.
We meet again.
If you'd like to stand, please, and repeat after me. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
You are Professor Mark Woolhouse.
I am.
You have helpfully provided a statement to this module of the inquiry along with other statements provided to previous modules. Your modular statement for this inquiry is dated the 14th of December 2023 and has the reference INQ 00036975. Is that your statement?
It is.
Do the contents of this statement remain true and accurate as of today's date?
They do, though we have sent a handful of further exhibits to the inquiry, but I don't think they materially affect this statement.
Thank you very much indeed. You're a Professor of Infectious Disease Epidemiology at the University of Edinburgh.
I am.
You sat during the course of the pandemic on the body called SPIMO between January 2020 and early 2022.
That's correct.
You're also a member of a group about whom we have heard evidence, the Scottish COVID Advisory Group, from March 2020. You attended that group regularly, apart from a 2-month absence from meetings in February and March 2021.
That's correct.
You did not attend the SAGE meetings that we've heard about.
I did not.
Thank you. You were awarded an OBE in 2002 for service to the control of infectious diseases.
I was.
You're a Fellow of the Royal Society of Edinburgh,
I am.
of the Academy of Medical Sciences and the African Academy of Sciences.
I am.
We've heard some evidence about your role in providing early information and advice to the Scottish Government, in particular through Dr. Catherine Calderwood, the then Chief Medical Officer. You've given some evidence about that to the inquiry already, but I'd like to ask you some more questions in the particularly Scottish context of this module. Could we have, please, up on screen INQ 0003524550? If we could go to, yes, that's the right one. This is a chain of emails which you have helpfully produced to the inquiry between yourself and Catherine Calderwood, is that correct?
It is.
And I understand that you first contacted Dr. Calderwood in connection with your concerns about the emergence of a new virus on the 21st of January 2020, is that right?
It is.
What prompted you to contact Dr. Calderwood specifically at that time?
This seemed to be a matter that very quickly would require the Scottish Government to engage with. And since I wasn't at the time part of any formal advisory system, it seemed to me the logical route to channeling my concerns to the government was through the Chief Medical Officer for Scotland.
And presumably, given the fact that you, as well as having contact with people at a UK level, contacted the Chief Medical Officer for Scotland, you were under the impression that the Scottish Government had the ability to do something about this?
Yes.
Health and indeed public health are matters devolved to the competence of the Scottish Parliament and hence the Scottish Government.
Indeed.
We've looked at some of the text of these emails before. I think the context, please correct me if I'm wrong, of this email is that it follows on from an announcement of recognised human-to-human transmission of the virus the previous day. Is that right?
That's right.
What was the significance of the emergence of that piece of information about the virus?
We already knew about cases of what was then actually called Wuhan pneumonia in those very early stages. And there was the possibility that these had been acquired from an animal source, a non-human source. And it is possible, there are many diseases like this, that the infection would spread from the animal, but could not then spread from person to person. So a human is a dead end from the virus's point of view. Now, that doesn't mean it's not serious. Some of these sorts of infections, like rabies, for example, around the world are very serious. But nonetheless, that kind of infection would not cause a pandemic.
So the evidence which had emerged the day before about human-to-human transmission was a significant piece of information which would affect your assessment of the likelihood of the virus transmitting and potentially reaching epidemic or pandemic proportions.
Well, yes, but it confirmed my fears. I had already received, I think on January the 9th or 10th, a report from, that was sent to me unexpectedly, of the Wuhan Municipal Health Authority that already was describing that this was quite a sizable outbreak and had been persisting for some weeks. So I was already thinking this is unlikely to be just an animal origin epidemic, as in the only cause of human infections is from animal sources. It was already, so I was expecting this news that it was human-human transmissible. I'd feared that for over a week, 10 days.
I see. So this very recent piece of evidence about human-to-human transmission had added to and confirmed your fears about previous information which had been made available to you earlier that month. Correct.
I thought we were going to have a pandemic, or it was very likely that we would have a pandemic from round about January the 10th.
Thank you. You say, it's on the second page of the page we have here in the second paragraph, there are some instructive parallels with the H1N1 pandemic in 2009 to 10. Indeed, one possibility is that this could turn out to be quite similar in some key respects, a widespread epidemic fueled by mild cases, but with mortality among vulnerable patients. Can you tell us why it was that you were seeking to draw to Dr. Calderwood's attention parallels with the 2009-10 H1N1 pandemic and the various features which you identified as being a possibility of the pandemic which you were predicting for the novel coronavirus at that time?
I think that was the most instructive parallel available. And it wasn't just the characteristics of the infection, which, as the inquiry has heard a lot of evidence for, turned out to be significantly different from influenza, but also the nature of the response. And I had been involved in the Scottish response to the H1N1 pandemic in 2009. And there were deficiencies in the response at that time, and I was very anxious that history didn't repeat itself.
Yes, I think we'll get to that very expression that you used in one of these messages. But what was it about the information that you had that suggested that it would be an epidemic fueled by mild cases with mortality amongst vulnerable patients?
It's a respiratory infection, and that's pretty standard textbook expectation for a respiratory infection.
As far as the ability to detect the spread and therefore significance of the virus, what is the significance of the fact that it would be fueled by mild cases?
That simply means that it would be very difficult to track by detecting people reporting with symptoms. You wouldn't see a lot of the cases, so you would need other ways of identifying those cases.
Because
they wouldn't know they were cases.
Yes, so people would have mild symptoms that they wouldn't necessarily associate as anything out of the ordinary, and therefore might not report for testing, such that chains of transmission might go undetected. Is that the broad idea?
Yes, and as you may want to discuss later, that turned out to be a huge problem.
Yes, indeed. At the moment, I'm focusing on what it was you were predicting. You're also predicting mortality amongst vulnerable patients as being a feature of a respiratory virus of this nature, based on your extensive experience.
Yeah.
You say, although in that paragraph you are pitching your prediction as a possibility, in the previous paragraph, based on the not unexpected announcement, as you've explained, of human-to-human transmission, you state that this will become a pandemic and therefore will affect Scotland. That was your position at the time?
Yes.
And that was why you wanted to bring this to the attention of the Scottish Government through the Chief Medical Officer?
Absolutely.
Thank you. Could I just then go to the next paragraph where you highlight, in light of your predictions and the particular features of the prediction you're making, what it is you think will need to be done to try to cope with this. You say such an epidemic would be difficult to track. As in 2910, what would be needed is an integrated surveillance setup that combines clinical surveillance, genomic surveillance and serological surveillance, the latter requiring an appropriate test. We, and I am sure many others, are working on this already. This should be unexceptionable. My reason for writing now is to emphasise that based on experience of 2910, that system needs to be put in place in advance of the arrival of the virus, so the sooner the better. If we wait until after the virus has arrived, then we will miss information of public health value, and our efforts to prevent the control of the pandemic will be compromised. So the message you were trying to convey was based on your previous experience of what you considered to be similar viral outbreaks. One needed to act fast in order to try to keep the spread under control.
Correct.
Can you help us a little bit with the requirement for clinical surveillance, genomic surveillance and serological surveillance? What would those different components have been aimed towards achieving?
So I'm actually taking this straight from what my team did in 2009, 2010 on behalf of the Scottish Government. They asked us to do this eventually, and that's the work that we did. There is a clinical surveillance system, not just in Scotland, but more widely, for influenza-like illnesses, respiratory infections, essentially. That's useful, but what we'd found in 2009 was it wasn't extensive enough. And what we were able to do, working with colleagues in Health Protection Scotland, was get that it's based around general practices. And we got that scaled up very quickly, and that provided very useful information quickly during 2009. Genomic surveillance, well, I don't know how much evidence the inquiry's heard about the value of whole genome sequencing. It wasn't something that Scotland actually was geared up to do in 2009. So again, my team, we had to introduce that. It was relatively new technology at the time. We had to introduce that into the process. And that was extraordinarily valuable, just as it was with COVID-19, but not nearly as advanced at that time. And serological surveillance, and that's, again, what we did in 2009. It's basically detecting people who have antibodies to infection. So it's tracking an infection by taking blood samples and detecting who has had the infection. So it's not the same as the PCR tests and the lateral flow tests that came along with COVID. And in this, I didn't anticipate those, but it was a very useful tool in 2009, this serological surveillance.
And obviously, as you said, you were seeking to convey a sense of urgency about the need to create these systems and develop these systems specific to COVID. What was your understanding of Scotland's ability to do that at that point?
So prior to this chain of emails, I'd been in touch with my colleague Chris Robertson at Health Protection Scotland, and through him with Jim McMenamin, who I believe you've already heard from.
That's right.
And so I was getting a sense of what level of activity was going on in Scotland, and I didn't get the impression that it was, in my view, treating this situation with the seriousness or the urgency that I felt it needed.
I see. So did that apply simply to the reaction to the information that was emerging, but also to the practical requirements that you were recommending needed to be put in place in order to deal with that threat?
Yes. So in a perfect world, I would, in this email, be pushing at an open door. And the reply I would get to that email was, "Thank you, Professor Woolhouse, we're already doing this." And I believe you heard from Gregor Smith earlier, and I watched his testimony, and he said, and I'm paraphrasing slightly, Professor Woolhouse is just telling us textbook stuff. We know this. And he's absolutely right.
Right.
I was. But the textbook stuff needs to be acted on.
Yes.
And the thing that I was particularly concerned about was, although I'm very well aware of all the systems in place in Scotland and elsewhere to respond to an outbreak, including an influenza outbreak, I was already convinced at this early stage that this was going to be considerably worse. And so I was really trying to push this. But I would have been very happy with the response to this email saying, thank you, we are already doing this.
Right. And you say this was your impression. I think from various materials, including your book, you were also in contact with other people in the UK at this time. You've mentioned Chris Robertson, you mentioned Neil Ferguson, Jeremy Farrar, and others, some in Scotland, I think, with whom you were discussing these matters around this time. Were they of a similar view to you? Was there a consensus?
Oh yes, absolutely, absolutely, no question. We were all very concerned
yes.
at this point. All those people you've mentioned there.
So, lest it be suggested that this was simply your view, this was a view which you had discussed and developed along with other experts in the field.
Yes.
You say in your statement at paragraph 186 that better surveillance coupled with genomic studies would have facilitated better advice and better decision-making during this crucial period. Had these systems been ramped up in late January and into February, as you had advocated, would this have been early enough to allow for the spread of the virus to have been restricted more than it was before the lockdown was imposed eventually in March?
Yes, so I'm suggesting a programme of gathering data, gathering information. There's a whole, obviously, another rather important layer of what you then do on the basis of that information. But obviously, if we have better information, we are better informed, we can make better decisions, which might well have the consequence that you outlined. But I'm here concerned with getting the information.
Of course. There is a theme, I think, which we've discussed with some other witnesses that runs throughout the testimony and the many documents you've provided, which is a frustration which I think you held and predated this period, and indeed had been the subject of some correspondence with Dr. Calderwood in the years prior to this, about the lack of data access for those like yourself in the research community in order to be able to provide the level of assistance, support, input that you would have liked to have provided in a situation like this. Could you tell us what the background to that was broadly, and whether these frustrations remained active at this time?
Well, the second point, the answer is a simple yes. The first point, that emerges again from experience in Scotland of 2009-2010 influenza. And you mentioned I was a fellow of the Royal Society of Edinburgh. We did a post hoc report of the management of that incident in Scotland, and we made a series of recommendations precisely about this, that we needed to have the mechanisms of obtaining, sharing and analysing data in place, ready to go should another pandemic arise. Quite a detailed report. And I already was aware that this report had not really been acted on, so that's one of the things about my frustration. What I wanted to know, what I wanted to happen here, me and others through the Royal Society of Edinburgh had recommended over 10 years ago. No, not quite 10 years, sorry, 2011, 12. So
right.
Getting on for 10 years ago.
Right.
And it hadn't happened, hence the frustration.
I see. We heard some evidence from other witnesses, including we heard evidence together from two Health Protection Scotland witnesses. You mentioned Dr. McMenamin, I think, and we also heard from Professor Nick Finn, who spoke, although he wasn't in Scotland at this time, spoke on behalf of Health Protection Scotland. And when they described their attitudes over this period, both, if I recall correctly, were keen to emphasise that the previous swine flu experience was a substantial factor in their thinking about the threat, but perhaps in the opposite way to the way in which you were using your experience of previous viral outbreaks. You were drawing on your previous experience, which led to you, I think, suggesting this was a significant threat, whereas it seemed that their evidence was to the effect that the swine flu outbreak was something that was making them more cautious about coming to the conclusion that this was a significant threat. I wonder if you could comment on that and whether the attitude, as I've characterised it from them, was a prevalent one at the time?
It was, and the reason is fairly straightforward, actually. In the swine flu turned out to be, by the standards of these respiratory infections, really quite benign. Its case fatality rate, the fraction of people who are infected and die, was somewhere in the order of 1 in 1,000, which is low. I mean, obviously it's significant. It's a public health problem and needed to be managed, but it's relatively low. The early estimates of the infection fatality rate for this virus were, I think that comes later in this email chain, somewhere in the order of 4%. Mm-hmm. Well, that's 40 times higher. So you can immediately see that this potentially then is going to be an enormously greater event. The reason why I personally, unlike my colleagues you've mentioned, leant towards the more concerning or alarming figure, because we knew, again, going back from certainly the first half of January, well before this, from genome sequencing studies done on material from China, that this virus was extremely close related to the SARS-1 coronavirus. That had a case fatality rate of 10%.
Right.
So from my point of view, we're in this territory. This is a very, very similar virus to something that had a case fatality rate of 10%. That's a completely different magnitude of problem than swine flu.
Yes.
That's why I...
So you are bringing together, I think it's fair to say, a number of different experiences of previous viral threats, swine flu, H1N1, and the information that you had, the original SARS, as you've just outlined, with its high infection fatality rate. Your view, bringing all of this evidence together, was not that there was evidence suggesting that this was not a matter for concern, very much the opposite. It was a matter of significant concern.
Very much the opposite, yeah.
Okay, thank you. You mention in your email the possibility that there could be mortality amongst vulnerable patients. We've heard significant evidence in this and other modules about the fact that Scotland, relative to other parts of the United Kingdom, had a relatively elderly population with significant health inequalities and comorbidities. Was it therefore all the more necessary, given this possibility of mortality against that background, to start to consider doing something to protect that large cohort of vulnerable patients in Scotland? Yes.
I wouldn't want to overstate my level of understanding of the situation at this very early stage. And there still wasn't good evidence as to what a vulnerable patient was for this. There were indications from previous experiences with SARS and indeed influenza. So we had some idea, but this was all quite uncertain at that stage. But that, as I said, seemed to be the most likely course this would take.
But if that possibility did eventuate, that would be a particular problem for the particular characteristics of Scottish society, given the pre-existing.
I would not pretend to you that I was thinking at the time that Scotland was particularly vulnerable to this. Just that Scotland was vulnerable to this. Full stop.
Did that start to become part of your thinking over the subsequent months?
Yes. It depends what you compare Scotland with, but yes. The vulnerabilities are one thing. The main vulnerability, as you well know, is age. So the very fact that the whole UK population is actually quite elderly by global standards was a concern.
Yes, indeed. Thank you. A number of these emails, if we could scroll up through the emails, we can see the reply. Scroll backwards, if you like, through the emails. You can see the reply from Dr. Calderwood, where broadly she says to you that she acknowledges your email and I think tells you that PHE and HPS, as it was at that time, before the advent of PHS, were actively considering the detailed surveillance needs and investigation required for this novel virus, and apparently recognising the value of those surveillance systems. How did you take that response Were you satisfied that it sounded like they had things under control, or were you expecting a little more given what you had said in your earlier email?
I don't regard actively considering as sufficient.
Thank you. If we go again back through the previous emails, we're going to one on page 4, which is dated the 25th of January. And you say, you write to Dr. Calderwood again, and you indicate there that you have discussed the matter with a number of others, including Jeremy Farrar, Neil Ferguson, as I said, and that they had independently reached the same conclusions and have advised Chris Whitty accordingly. You provide some further information and then state that based on the case fatality rate, I think the infection fatality or case fatality rate you mentioned a moment ago of 4%, if you were to put those numbers into an epidemiological model for Scotland and many other countries, you would likely predict that over about a year, at least half the population will become infected. The gross mortality rate will triple more at the epidemic peak, and the health system will become completely overwhelmed. We can formalise those predictions, and there are many caveats to them, but those are the ballpark numbers based on information from the WHO. Please note, this is not a worst-case scenario. This is based on WHO's central estimates and currently available evidence. The worst-case scenario is considerably worse. Again, what were you trying to convey to Dr. Calderwood, again, about your developing understanding, your conversations with others, and information that seems to have developed in the days since you last wrote a few days before?
Yes. So the work that the actual science that we've started to do is at this stage, at this early stage, is trying to understand, in context of my team's work, the scale of the threat to Scotland. And I'm reporting on what we now assess the scale of the threat to Scotland to be.
Yes. And you in a couple of lines down, you say, your reply to my earlier email did not give any indication that here in Scotland we're preparing for an R02 CF 0.04 event, and I don't have the sense that we are from my networks here either. So I think they are conveying the information that the case fatality rate is 4%, as you said earlier, which is an alarming case fatality rate. Is that right?
Correct.
And that the R being 2, that is the R0 of the virus, which is an indicator of its transmissibility. Is that correct?
Yes, and actually that one turned out to be an underestimate. So
yeah, indeed. But even with those numbers, yes. You are expressing there, as you've told us in your evidence, a degree of dissatisfaction with the level of the urgency within Scottish Government.
Yes, and again we come back to Gregor's comment that this is textbook. Yeah, it's textbook. My undergraduates could do this calculation.
Yes.
My undergraduates could come up with this assessment. This is not difficult.
Yeah. Well, one might say that makes the lack of action all the more questionable and perhaps culpable.
I think I better leave that to the inquiry.
Okay, thank you. But in any event, you were, as I say, trying to convey, applying basic epidemiology, if that's correct, to the specific characteristics that had emerged from the science, the R0 and the case fatality rate. To you, it was fairly obvious that this was going to be a huge problem.
Yes, and you mentioned the book I wrote. One of the things I put in that as the final explanation in my mind for why this wasn't landing in Scotland or elsewhere was you put all this very, as I say, fairly basic information together, and what you get is an unfolding catastrophe. And I think a lot of people simply couldn't get their heads around that.
Right.
Even though, as I say, this is very simple.
Mm-hmm.
So you add this number and this number and this number and this number, and you get a catastrophe. I think they couldn't take that final step.
Yes.
Put all this information together and what's going to happen. And of course,
Are you, I think, therefore, you're attributing to the medical advisors of the government at least the ability to do the basic epidemiology and arithmetic. But are you suggesting that perhaps, given the number that came up with, they rather froze?
yes.
Thank you. Could we look at go further back to page 2, please? This is a further email which you sent on the 26th of January, so that the very next day. Just while we're getting that, one thing that was mentioned yesterday by Professor Sridhar that I just wanted to ask you about, a couple of things about the way in which information is communicated to people like yourself. She mentioned something called PubMed, which, as I understand it, is a source of information about developing epidemics or developing viral threats. Is that right?
ProMed.
ProMed, sorry, ProMed.
Yes.
And could you just tell us a little bit about what that is and the extent to which that was used by you and others to be able to access information about the emerging virus?
It's been around a while. It's I don't know quite what you call it. Maybe something a bit like a blog, but it predates even blogs. So it's a loose association of experts in the field who report to one another concerning events to do with infections.
Right.
Of which in a given year there will be dozens, if not hundreds, around the world. And that, I'm inferring that Devi used this as one of the sources of information. I actually didn't use that one.
Right, okay. And we've also heard some evidence from a number of the witnesses who have helpfully provided our Rule 9 responses of, not necessarily at this period, but in the period after this, as information starts to emerge more about the use of preprints in analysing the emergence of the threat. Could you tell us what that is and the extent to which that was used in trying to understand what the threat was and the characteristics of the virus, etc.?
Yes, the gold standard for communicating scientific knowledge, of course, is the publication of a piece of research in a scientific journal, which is done subject to peer review. So it's looked at by experts, it's judged to be sound, and it's published. And that remains the gold standard. But in a very fast-moving situation like this, that whole process, well, I mean, quite frankly, it can take up to a year sometimes, and for some circumstances longer. So it's clearly far too slow. So preprints is the practice of taking the paper that you've submitted or you're planning to submit, but publishing it immediately. And it's made very clear on the preprint servers that this is not peer-reviewed research. So for that reason, it hasn't been quality controlled, but it's put out there so that the rest of the scientific community can see it. So it's basically a very fast way of communicating your research outputs, but it loses the quality control element of peer review.
Thank you. The reason I've asked you those questions, Professor, is that a number of other people, including the PHS representatives, suggested that the way in which evidence emerged over these early months, if we put it that broadly, from January onwards, about the nature of the virus and hence the nature of the threat, was unreliable or contradictory or difficult to interpret. It doesn't seem to be the case, even at this very early stage, and in fact you've referred to you developing views about this even earlier than this correspondence, that you, although no doubt are taking that into consideration, the reliability of the evidence, that is restricting you from reaching the conclusion that this is a very, very significant problem about to happen. Could you tell us about why it is that you felt confident enough in your professional assessment to be able to express these views despite those concerns expressed by others?
Well, one very simple way to do it is if somebody from, whether it's a scientist from China or the UK or anything, is publishing, wants to publish a paper, something they put up as a preprint. Beyond the preprint, someone would have to peer review it. Mm-hmm. That person would quite likely be me.
Right.
So I felt perfectly qualified to peer review the evidence I was seeing myself.
Yeah. So you were able to evaluate what was in the peer review and use your extensive experience to be able to reach a judgment about whether this was reliable and sufficiently reliable information to be able to communicate these sorts of messages to government.
Yes, and during the pandemic, I didn't have time to do this for the scientific journals, but it's a job I routinely do for scientific journals. So I was simply doing it in real time in a different context.
Thank you very much. In this message, you go back again, as we said, this was the next day, and then you set out a number of different scenarios. Could we just scroll down a little bit further than that? There was one aspect of this where, just a little bit further than that, thanks, it's where you get to the measures we could consider are you talk there about a vaccine being a part of the solution, I think. And what at that stage would you have been thinking? Obviously, a vaccine would have been a very useful thing to have, but in terms of planning, what would your realistic expectations have been about when a vaccine might become available based on your extensive previous experience?
At that time, I think the fastest a vaccine had ever been rolled out from scratch was 4 years previously. Obviously, there was going to be a great need to accelerate the process. I really got that estimate of a year through correspondence that you already mentioned, particularly with Jeremy Farrar, who's director of Wellcome Trust and is very, very well connected with the vaccine manufacturing base. So I agreed with Jeremy, but I think his estimate was much more authoritative than mine, and that was.
So you just scroll down a little bit further. You mentioned antivirals there. Again, you say effectively that's something for the time being at least we're going to have to live without. So I think you're then pointing towards the need for what I think are non-pharmaceutical interventions in order to try and deal with the situation. And you mentioned there a number of different things with which we subsequently became familiar: case isolation, infection control, and contact tracing, social distancing. But also the thing I wanted to focus in on particularly was public messaging. What was it that you thought, you rather there suggest you hoped that the government was already doing something about that, but what sorts of public messages do you think should have been emanated, been sent out from that time onwards in order to try to manage the balance required between not causing widespread panic, but allowing citizens to be part of a bond of confidence with government about how their own health and safety is being managed?
You summed it up perfectly. That's exactly what I was worried about.
Right. So you think that there required to be some level of public messaging that reflected the need to balance those two considerations?
Yes, and I was doing, as part of my role at the university, a good deal of media work, even at that stage, and I was having to walk this tightrope myself. And it would have been very helpful if the Scottish Government had actually made some pronouncements that could then be discussed by the media and commentators and so on. So I was tiptoeing around exactly the problem that you identified.
I see. But is it correct to say, because this is one of the things identified here, that a level of engagement of the public appropriately pitched was necessary?
Yes, but I wanted it to come from government. Obviously one thing I could have said in media interviews at that stage was what's in these emails.
Yes. Yeah.
For rather obvious reasons, I did not want to do that. That should not come from me.
Absolutely.
But it wasn't coming from anyone else. Well, that was the problem.
You were, I assume, speaking to the very person in these emails from whom you thought it should be coming,
yes.
the Chief Medical Officer and the ministers whom she advised.
Yes.
There was then an exchange of emails, further emails, where you provided more information. Just for the sake of the record, the 31st of January email is INQ 000103352. And then in a further email, which we've seen, which is INQ 000103215, we've seen an email which was sent, not involving you, but it was sent by Dame Sally Davis, I understand was the former Chief Medical Officer to the UK government, to Dr Calderwood on the 5th of February, in which Dame Sally Davis oddly introduces you to Dr Calderwood. Was that email the result of some contact you had with Dame Sally Davis about the position?
Yes. So we've discussed my frustration with what I continue to perceive as the lack of action. So I'm surprised you don't have the email, but maybe you have it somewhere else. I wrote to Sally, who I knew. And the email's there somewhere, but I'm paraphrasing slightly. I'm saying, Sally, can you get Catherine to listen to me? Because she's not listening.
Okay, thank you. And I think, again, if we have a series of emails here, again, all joined together under this reference. If we scroll up, there's a reply on the 6th of February to that message. You're copied into these messages, I should say, in which indicating that you had emails in the very recent past with some extremely helpful modelling estimates, she says to you, as you're CC'd in, let's find a time to meet face to face. You eventually did have a meeting with her, I think, but on the 28th of February, is that right?
Yes, that's correct.
Again, did that timescale between your original contact, the need to try to engage the assistance of Dame Sally, and the date of the eventual meeting give you the impression that Dr. Calderwood was taking on board the level of the threat that you were trying to communicate?
I was less concerned about the actual meeting at that stage. What I hoped that Sally Davis's intervention had done would be suggest to the CMO that it might be perhaps wise to revisit my advice and what I've been telling her and take action accordingly. So I didn't push for that second meeting. I left that to the CMO's Scotland.
I see. Could I just run through some of the things that I understood happened roughly between the time of this email and the eventual meeting on the 28th? Just there, in order to try and get some key indicators of the developing knowledge of things that seem to us to be significant in the elevation of the threat. A meeting of SAGE took place on the 4th of February, in which it stated, on the basis of their analysis, that asymptomatic transmission cannot be ruled out and transmission from mildly symptomatic individuals is likely. It also indicated that human-to-human transmission outside China had occurred. Now, obviously, you've given us a lot of information across the various modules about the significance of asymptomatic or mild transmission. You had, in fact, predicted that it was at least a possibility sometime before that this would be the type of virus which could be transmitted by mild patients, and you've explained to us the significance of that. As at that SAGE meeting of the 4th of February, what was your view about the reliability of the evidence base that the virus was going to be transmitted by either asymptomatic, pre-symptomatic, or mildly symptomatic patients?
Thank you for mentioning pre-symptomatic, because it's very, very important on this. But the data on this was emerging in a very piecemeal way from China at the time. And me and many other epidemiologists around the world were trying to make sense of this data. I had a slight inbuilt advantage in my research group at the time. I had two very able Chinese students who were very useful in giving me intelligence and guidance as to what was going on in China and how we should interpret the sorts of information that was emerging. But China, and I believe the WHO, were at the time actively suggesting there was not much undetected cases, mild cases, that this was not the pattern. It was completely wrong, but that's what they were suggesting at the time. So this created a lot of doubt.
It might be difficult to know how many undetected cases there were because the mild asymptomatic or pre-symptomatic spread means it's hard to detect them.
Yeah, but they did surveys, but they didn't interpret the results the way I interpreted the results.
Yes. So at what point over this period, did the evidence base, which, as you say, was not entirely satisfactory, although you had the advantage of two able Chinese students assisting you, at what point over this period did it become apparent to you, based on the kind of judgment that you have explained you apply to evidence and papers, that asymptomatic, pre-symptomatic, or mild transmission was going to be a likely feature of this particular epidemic?
I don't think the evidence for that became firm, the sort of evidence you would publish in a scientific journal for quite some time. I don't think that happened in February.
But it was definitely part of the thinking.
Oh yes. Oh no, it was absolutely part of the
elsewhere at this
thinking. We were concerned, but again, the evidence hadn't emerged. There were systems set up which Scotland was involved in an exercise called the First Few Hundred. I think you've heard of
Yes,
that.
yes.
And that was designed to provide, among other things, this sort of information. But of course, in order to activate something called the first few hundred cases, you have to have 100 cases here in the UK or in Scotland or wherever. And we were nowhere near that number.
Yes, of course. Well, as far as testing is concerned, that was something else I was going to ask you about. The earliest record that we have of tests being conducted in Scotland is, I think, around the 10th of February. But when was it that a test in its most basic form, if you like, was available?
Wouldn't have been long before that. I don't think that's. I don't think there's any. I don't have any concerns about that.
Yes.
I think that first test date was pretty good.
Yes. We know that because there were 57 tests conducted that day. All were negative, so we're not contributing to positive tests.
Yes, but the principle is established, and I'm glad it was. That was a welcome development.
Absolutely, thank you. You met again, Dr. Calderwood on the 28th of February. We have a briefing note, which is INQ 000103216. This is a note, I think, that you sent her in advance of the meeting. Further down towards the end, you sent her a lengthy analysis of the position as at that date, as things have developed since your initial correspondence. And then a bit further down, thanks. Yeah, you say there are two scenarios we particularly want to avoid: doing nothing, as that is likely to result in the health system being overwhelmed in a matter of weeks once an epidemic takes off; implementing extreme social distancing measures that, sooner or later, have to be relaxed; and then, having already paid a high social and economic cost, experiencing a delayed epidemic that still overwhelms the health system. So there's a degree of balancing, I think, required there as well. What was it you were trying to urge in advance of your meeting in this lengthy, detailed briefing note what were you trying to urge upon Dr. Calderwood as important things to bear in mind in this overall scenario assessment?
Yeah, exactly what I say there. I mean, it was clear to me at that stage that we were going to have to walk a tightrope between an epidemic that took off basically and overwhelmed the health service, or wasn't thinking of lockdown in those stages, but at that date, but some very severe social distancing restrictions that would be extremely damaging in their own right. We were walking between two very, very unsatisfactory outcomes. So this was going to be difficult.
Yes. What was your view at this point, towards the end of February, about what Scotland could have done in order to try to handle the threat as it was at that point?
Well, we started to discuss this in the meeting. I think it's the next day after this. So it's I don't know if I say it in using that phrase in that meeting, but one of the things we've been working on there was this idea that earlier intervention can be less drastic intervention. So if you want to avoid these very severe social distancing measures, then actually you're going to have to intervene earlier. But I'm not sure I was quite at that stage in my thinking at this meeting. I think that maybe emerged. First time I did a briefing on that, I remember that one was March 4th.
Right.
So I may have mentioned it to Catherine at that meeting. It was certainly in my mind, but I don't think we'd actually written it up, that earlier intervention could be less drastic intervention.
There's some other email correspondence that we've seen. We could take that one down there. Thank you very much. Some other correspondence relating to the meeting, slightly after the meeting, in which one of the things that you refer to is social distancing measures were very likely to need to be introduced in Scotland, possibly very soon. In your statement, you say that meant days, not weeks. And you also point out that there would be a need for a clear exit strategy, and also some level of analysis of the effect of social distancing economically, socially and psychologically. So you're setting this out presumably at or immediately after the meeting. Could we just look at those different components? At that stage, as far as the measures that were concerned, what did you think needed to be done? The second was the exit strategy, and the third was some level of analysis of the effect of social distancing measures emotionally, economically, socially and psychologically. If you could explain the significance of those and your position at the time.
Yeah, so it is, as you said, I'm setting out the need to balance harms. And this is absolutely fundamental to public health. In public health, you're always balancing harms, even if the harms are just monetary costs. But it's always a balance you're trying to strike. My concern here, and this comes back to the scale of the crisis that didn't seem to be landing in government at that stage, is both harms, the harms that the virus could cause and the harms that the countermeasures could cause, were immense. Mm-hmm. They were absolutely enormous. So when I'd been doing this sort of exercise over the years of trying to make an intervention, a health intervention, efficient, so not too costly, not damaging other ways, the stakes were nowhere near as high. Mm-hmm. There's a little bit of wiggle room. I mean, you get it wrong this way a bit or that way a bit, and it costs the government a small amount of extra money. But here, the stakes are absolutely enormous, mm-hmm. and we have to find the right path. Mm-hmm. If we go too hard or too soft, we're going to end up paying an enormous penalty, and this is very obvious to me. Well, as you saw from during late February, that we were in this position. Mm-hmm. So I'm trying to lay the ground for this sort of decision making that's going to have to happen. Yes. If we're not and damage.
And I think you tell us, or these documents show that you are not aware of any. You're talking about the other side of the balance, if you like. We've heard something which we'll come on to later, which the Scottish Government introduced after this in April, that we call the 4 harms strategy. The first harm being the harm of COVID itself, the other harms being harms caused by the measures taken to combat COVID, the non-COVID health harms, the societal harms and the economic harms. Is it your understanding that at this stage within Scottish Government no analysis had been done of the effect of even the social distancing measures short of lockdown, which you are suggesting might be contemplated?
None at all, as far as I'm aware.
Okay. The other element of what we discussed there was the exit strategy. Why was it important to have an exit strategy?
Simply because the sorts of interventions, the social distancing that were being contemplated at that stage were clear, and that include things like school closures that were on the table, were clearly very, very harmful. And equally clear, they could not be implemented indefinitely. We couldn't, well, it turned out to be a lockdown in the end. We couldn't lock down indefinitely. So the lockdown had to come to an end. So what would be the strategy, the exit strategy? What would make you decide that you could exit lockdown? And the reason that's important is because the exit strategy is going to also determine how long the lockdown is. So what are we preparing for? So you could imagine that came up later, the sort of circuit breaker type approach where actually the lockdown is just a week or something, or all the way up to an indefinite lockdown until we got a vaccine. So there's a range of possibilities. So and it's very difficult to advise on what the best strategy is unless you know what the government is willing to contemplate. I mean, can I give you a very simple example?
Absolutely, very helpful.
If the government was willing to contemplate an indefinite lockdown, and forget all the costs and the harms that would do, but that they were willing to do that, then my advice would be, right, do it now. Lockdown now. That's the way to minimise the impact. But obviously they can't do that. We'd be locked down for possibly years if we'd done that. It's completely impossible. So as soon as you accept that the lockdown has to come to an end, then the question arises, well, then when is the best time to do it? And suddenly you're in a different space. The decision is no longer nearly so easy. And the reason this is causing us all such concern at that time, and there was a lot of work going on about the best timing and duration of what turned out to be a lockdown, should be, so the severity of the intervention as well, is because it hadn't been done before. Because we'd never contemplated lockdown as a public health policy at all. This was completely new. We ourselves, I mean, you kindly call me an expert in the field, but I've never thought about this before. Never contemplated it. So I got my team frantically working, how is this going to work? What's it going to, what's it going to look like? How long should it be? When should it be implemented? What's the exit strategy? We're working very, very hard to try and understand something that, if we'd known it was going to be on the table, we would have spent years researching before, so that we understood all the nuances and all the trade-offs and how actually you should do it. But none of that work had been done because no one around the world had ever contemplated lockdown. So we were frantically trying to catch up.
Which explains why I think that your correspondence at this time isn't referring to lockdown or anything like it. It's referring to social distancing measures, or even more extreme social distancing measures, because lockdown simply was not part of the narrative and had never been prepared for.
No, so of course it was on the radar because at that stage the city of Wuhan had been locked down.
Yes.
Obviously we were very aware of that and that had been widely discussed. But I think the realisation that something like a lockdown would have to be contemplated for Scotland took rather longer.
Right.
And,
did you have the impression over this period and up to the point at which the lockdown actually occurred that there was any clear exit strategy in the mind of the Scottish Government?
In the end, when we went into lockdown, I don't think they had the faintest idea how long we would be in it for.
And as regards the matters we discussed, the systematic analysis of the effect of the lockdown or social distancing measures economically, socially or psychologically, did you have any impression that any such assessment had been done within Scottish Government?
Absolutely none.
You met with Dr. Calderwood again on the 6th of March, and there is another email follow-up in the same way as you'd done on the previous one, summarising your position. There's one element of this advice at this stage that I'd like to just draw your attention to, specifically to ask you some questions about. You see there are 3 social distancing measures informed by the modelling work of Imperial College and communicated through SPIM. It's the third one I was interested in asking you about, if you could explain what one of the things that you're suggesting is that there should be a policy of cocooning populations about the age threshold that you've mentioned. What is cocooning, and why was it part of the strategy that you were proposing might be contemplated by the Scottish Government at this time?
So our understanding has developed considerably by this stage. You pointed to my January 21st email where I identified that there would be likely to be a subpopulation of very vulnerable people. We now had very good data that there was tremendous variation in the risk with age. So the idea then is, well, how do you protect people who are very vulnerable? This seems to me, I have to say, to be actually the absolute #1 public health priority for Scotland and everyone else. We've identified a subset of the population that's at very considerable risk. We spoke about the case fatality rate, and we said that a case fatality rate of 4% was high. But in the elderly and the frail, it's way higher than that. So these people are very, very vulnerable. So how do we protect them? And I hadn't thought of this concept of shielding as it eventually was introduced, which is basically asking a lot of people in the community to protect themselves. So we had this idea of actually protecting people by protecting the people around them. So carers, family members, same household, that we had to pay particular attention to this. So that's what I was proposing, and that's an idea that we went on to develop
So
cocooning
months. Then is protecting not only those vulnerable people, but the people who would be likely to engage with those vulnerable people, their carers and so on. Is that right?
Yes, likely, but not through choice, but through necessity. Because elderly people, but particularly, of course, elderly people with other risk factors, other comorbidities, need care, whether it's in the home or it's in a care home, or even some in hospital. This is a subset of the population that really couldn't socially distance. It's just not possible. They can't.
Yes.
So clearly that wasn't going to be, unfortunately, was the strategy that was implemented, but just telling people to isolate themselves. But it seemed to me that we needed to actually we couldn't isolate themselves, so that wasn't going to work. So how do we do it? And we do it by cocooning.
Yes, I see. Was cocooning a policy which ever formed part of the Scottish Government's response to the pandemic?
No, and that wouldn't have mattered had somebody, there's a lot of very smart people thinking about this problem, come up with a better way of protecting the vulnerable population. But what we got was shielding in the form that it was introduced in Scotland, which in the community anyway was basically telling people to cut all contacts out, which there's lots of evidence now that didn't work particularly well, and I can give you chapter on verse as to why it didn't work if you want. But yeah, that didn't seem to me, even at this stage, to be a very good approach.
Thank you. There's a comment there as well, just on this particular suggestion, that Gregor, who I'm assuming is the now Chief Medical Officer, raised the point that there might be vulnerable people below the chosen age threshold as well. Personally, you're right, I don't see any reason why risk factors other than age couldn't be included in a cocooning policy, but as for the clinicians to advise what those might be. So you've obviously identified age as the main risk factor on the evidence that you've seen, which of course turned out to be absolutely right. But there's a suggestion made by the then Deputy Chief Medical Officer that we might need to consider our other groups vulnerable to the virus as well, and you are open-minded about the possibility of doing that because you recognise that there might be such groups who could be protected by similar mechanisms.
Correct.
Thank you. Could we just go down, have the whole email up as well, please? Over the page, I think. Yes, do you conclude this email by saying one final point, perhaps the most important of all? A lot of work went into making containment work, quite rightly, but it hasn't, as was to be expected. A lot of work is now going into making delay work, quite rightly. It may work or partially work, but there remains every likelihood that it won't work well enough to prevent an epidemic that does sooner or later completely overwhelm our health systems. This is not a prediction, but it is an entirely possible scenario. If it happens, it could happen within weeks, so I do think that we should start thinking about the mitigation phase now. Can you summarise for us what you were trying to convey as to the strategy at this stage, what needed to be borne in mind as strategies started to be put in place in the weeks after this?
Yes, so the UK government had this strategy, containment, delay. There was a research arm, which is a little bit of a diversion, but so containment, delay and mitigation. And this was, Chris Whitty, I think, was...
Yes, I think it was part of the UK Coronavirus Action Plan that was launched on the 3rd of March, to which the Scottish Government also subscribed.
Thank you. You're right. So I'm now trying to tailor my comments to fit in with the actual plan. I mean, there is now a plan, so that's progress. But I'm trying to tailor my comments to fit in with that plan. But I don't think that plan is going to work.
Yes. And what is it that you are counselling particularly about the dangers that plan might not work?
Well, I mean, what I'm saying is quite clearly that we should start thinking about mitigation, which is basically, okay, how do we deal with the fact that we're actually going to have an epidemic? We haven't contained it. We've delayed it as long as we can, and here we are. We have a pandemic. What are we going to do?
Did you understand over this period, did you take the Chief Medical Officer and other medical advisors to the Scottish Government with whom you were speaking to be receptive to your advice in the period from January up till the first lockdown, or not?
Well, we've discussed the difficulties I had getting myself heard up until February, so I think the only answer I can give you is no, I wasn't. I feel it did change, the tone did change in March, and that coincides with Gregor Smith getting more actively involved in the discussions I'm having with Catherine Calderwood. And I think that the pace did pick up, certainly in the first week in March.
Was Gregor Smith then considerably involved in the planning as far as you're concerned around that time? It wasn't simply Dr. Calderwood?
I don't know. I'm simply referring to his involvement
With you.
in the correspondence with me.
Yes.
And he was starting to ask questions that were the sort of questions I would,
Yes,
wanted to be
we've
asked.
heard evidence from him, for example, that he attended a number of the early SAGE meetings as an observer where he was gathering information, and he was obviously then part of the discussions with you.
Yes, but I mean, we've discussed before here that I don't think, and many other people think, that those early SAGE meetings were particularly doing a good job of raising the alarm.
Thank you. After this, you, of course, were attending SPIMO, and you communicated, I think, some messages with information about what had happened at those meetings in early March to Dr. Calderwood and Dr. Smith. Is that right?
I did. So this became a modus operandi for us, that I would brief the pair of them on the outputs of SPIMO. And I think that was important. There were, as you well know, there were many sources of information coming in. But in terms of the sorts of questions that needed to be tackled then, SPIMO was absolutely the repository of expertise and knowledge. And so I think it was, I felt it was important that they were fully appraised of what SPIMO's thinking was.
Okay. We've discussed the absence of certain features of the Scottish Government strategy before the first lockdown, but in that regard, what was your understanding at this time within the Scottish Government of their planning with regard to the way in which Scotland might deal with a second wave of the virus were it to eventuate?
I gave in my briefings that we've been discussing to Catherine Calderwood, so this is, well, I think actually some of it is even before we had cases in Scotland, but we have some idea of the sorts of social distancing intervention we might need. I said then that we were going to get, well, not that we're going to get, as you well know, I don't do that, but we were very likely to get, should plan for, the possibility of a second wave. And do you want me to give the reasons for that?
Yes, please, yes.
Right. The reasons for that is I was acutely aware that lockdown, or any combination of social distancing measures up to and including lockdown, would not solve the problem. All they would do was delay the problem. And the first manifestation of that delay is, okay, you get another wave. Mm-hmm. And then you push that, and I shared this scenario with them. You push that one down, the second wave, which, as it happens, in the briefings I gave, was September 2020, the second wave, so pretty close. And you quash that one down, and then you get another one in the early part of the next year. Now, there's no way you can predict with any precision how something like this is going to unfold over such a long timetable. So we wrote in very big letters on our graphs and briefings on this, this is an illustration, not a prediction. This is the sorts of scenario that are coming up when we do our work, and we're sufficiently confident in something like this happening that the government should be aware of it and should be planning for it. I don't think they had any understanding, not just in Scotland but in the UK, that they were going to get a second wave. That was the likelihood. That they should be planning the expectation they're going to get a second wave. I think there was a general belief that we would lock down, perhaps for a few weeks, and somehow the thing would be over. Extraordinarily naive view, but it clearly was circulating in the political circles around the UK. This was a temporary measure.
And indeed, contrary, as you said, to the advice you were providing about your experience of how these things tend to go in the briefings you were giving directly to the Scottish Government.
Yeah, more than how they tend to go, and based on the best analysis we could possibly do of the data on this particular infection in the UK, in Scotland. So no, not just based on expert guesswork. A lot more to it than that.
At a general level as well, another thing, you say this both in your book and also in the evidence you helpfully provided to the module, that you had the impression that the Scottish Government's policy with regard to the management of the pandemic was that no death from coronavirus was acceptable. I'd be interested in knowing how you got the impression that that was the policy, if you like, or the approach, and also why it was you think that that policy cause significant problems?
So I thought it because the phrase appears in the Scottish Government's, I've got it here, Framework for Decision Making, published in
The April document that I referred to earlier.
2020, and because, as I recall, the then First Minister said it several occasions. That's why I thought this was.
Thank you. And the second part was why, if it is the case that you consider it to be a problematic approach, it was a problematic approach.
It's empty rhetoric. It misleads everybody. Misleads the public. It gives an entirely false impression of what the future holds, how this pandemic's going to look. The idea implied by no COVID death is acceptable is a world where no one dies of COVID. That had gone. That had gone from December 2019. That was, as it turned out. But certainly I was clear it had gone by February 2020. And that's true because this year, 2024, current rates and similar to last year, hundreds of people in Scotland are going to die of COVID. Is that acceptable? Well, we seem to be accepting it. I mean, there's no great public health effort going on here to spare those hundreds of lives that are going to die of COVID. And as an aside, I think we're now not paying enough attention to COVID. Now it's a serious infection. It's killing people. May I go on?
Yes, please.
The second issue is, okay, how are you going to achieve this no deaths is acceptable? Well, the only possible way I could see of achieving it, other than literally some miracle cure, but let's leave that aside, is a zero COVID policy. And as I've explained to you before, the corollary of a zero COVID policy at that stage, this is April 2020 we're talking about, is indefinite lockdown. And it would still fail eventually. And this was being discussed at the time, and of course zero COVID did fail globally eventually. And so therefore it was never deliverable. And the other thing that upset me about this no death from COVID is acceptable, it devalues non-COVID deaths. And that isn't just a sort of philosophical complaint. The intense, very strong advice in Scotland to spare the NHS, particularly during the first wave, and not bother the NHS if you didn't absolutely need to, led to a huge spike. Well, first of all, it led, as you expect, to a fall off in the cliff, and the EVE project of which I was a part studied this on attendance at A&E or admissions to hospital. They just fell off a cliff. Most of the hospitals in Scotland had their quietest time in living memory during the first wave because no one else was going to hospital. And a lot of those people should have been in hospital. And in UK, thousands of them died at home. There was a massive spike in this. In Scotland, I think it was probably hundreds. I wouldn't want to put an exact figure on it. These people died. And so they died because the focus of the government was on preparing the NHS Scotland for COVID and concentrating on that. Because no COVID death is acceptable. Other kind of deaths apparently are. And they rose.
Thank you, Professor. To put that in the language of the Scottish Government framework, there was a significant focus on harm one, COVID-related harm and death, but too little concentration on harm two, non-COVID-related harm and death.
Absolutely. And that killed people.
And one, it would be reasonable to assume, would it not, you mentioned the non-COVID deaths, but of course there may be many people who have suffered significant morbidity as a result of not attending the hospital, whether that resulted in their death or not.
Well, indeed, but I mean, the non-fatal health harms went beyond that, and we might come to this. There was a study looking at the sort of health effects of both COVID, but also the implications of lockdown. So the indirect effects of the countermeasures, and that showed, by their best estimation, this was done by the Office for National Statistics and the Department of Health and Social Care across the UK, that actually those indirect harms over, not so much during 2020, but accumulating over time, would be considerably greater than the harms that would be caused by COVID. Sorry, having gone down this route, I must add an important rider.
Yes.
That is not a reason not to intervene against COVID. If you don't, then that side of the scale increases enormously. So, but it is an indication that we haven't got the balance right. So it's confirmation. It's another way of looking at the problem that you just highlighted as in terms of neglecting harm two. This is another piece of evidence said, yes, we've neglected harm two, but not just in the short term, in the longer term as well.
Thank you. If that's an appropriate moment, lady.
Professor, as you know, we take regular breaks for the stenographer. I shall return at 11:30.